Good afternoon, everybody. In this era of anti-VEGF drugs, which eclipsed all other treatment modalities, the question is, what is the current role of transpupillary thermotherapy? And I would first discuss the subfoveal treatment options, which still we are using subthreshold TTT in subfoveal lesions, and then we will discuss what are the extrafoveal treatments that we do with transpupillary thermotherapy. The primary indication for subfoveal treatment would be chronic CSCR. Here, you know that with very low and deep prolonged hyperthermia in TTT, there is vascular thrombosis and then the blood flow stasis and decreased leakage, which helps in chronic CSCR, where choriocapillaries are the responsible lesions for this disease. Also with that, the modest thermal elevation that happens with TTT, there is RPE modification by migration, transformation and reproliferation. So since chronic CSCR is a diffuse choroidal disease, choriocapillary disease, there is a potential with transpupillary thermotherapy, and very importantly, subthreshold power has to be used. Really subthreshold. We found that 50% of the threshold power is all that is required in chronic CSCR because there is no proliferative tissue here. And tailoring the treatment for maximum treatment effect and minimum toxicity is essential in treating patients with CSCR because they usually have good vision, baseline vision to start with. So, and the subretinal fluid under the macula actually protects the neurosensory retina from any thermal damage in chronic CSR. So currently in our, we use only in chronic cases more than 6 months, and as Dr. MPS said, subfoveal leaks, subfoveal PEDs or thick subfoveal fibrin, which I will be demonstrating these cases now, or when there is a diffuse RP epitheliopathy and leaks, diffuse leaks or ooze at the macula. So, and 50% of the time PDT is unaffordable, and or if it is contraindicated, then we offer this patient to the treatment to the patient. Here it is a 810 diode laser, Oculite SLX Iridex laser we use, and put 60-second laser burn. Still we use fluorescent angiography, not the ICG angiography, to avoid unnecessary over-treatment. And the greatest linear dimension is measured based on the mid-phase fluorescent angiography, and we go for a threshold test burn, and based on the test burn only you decide what is the power to use in that particular patient. So once you have a small slit beam, that is to identify any blood vessel. So infranasal quadrant, an extramacular threshold test burn is found, and from lower to higher power you do this until you get a graying of the retina. So that is the threshold power for that patient. So once you find the threshold power, then take that same spot, 1 to 3 millimeter spot, take it to the foveal area, reduce the power by 50%, and you can treat the fovea and subfoveal leaks and subfoveal PED, subfoveal thick fibrin, all these things. It's very safe and effective. We will come to the results after this. So with this 40% of the threshold power, and retreatment is done after 6 weeks. If the fluid is still persisting in these chronic cases, then we increase the power by 20% from the baseline and retreat the patient if necessary. So we will go from some simple cases now. This was the case which Dr. MPS was mentioning. You have a more than 6 months, you have a subfoveal smokestack leak like this, persistent fluid. You can see the defects, RP defects under the fovea. Go for a 50% power subthreshold TTT and the fluid is gone. Or a little more complex case where you have a thick fibrin and subfoveal PED here. You can go for again this is a post-treatment picture. The fluid has gone, only the PED is remaining under the fovea. Again here you don't have much fluid here, only thick fibrin is seen under the fovea. Again a 50% from the threshold. the fluid is gone, only the PD remains. You can have very complex cases like this where exudative RD and thick fibrin under the macula. You have ripped RP following a focal laser. So you have this exudative RD coming to the macular area. So subthreshold TTT after the first visit, still the fluid and fibrin are persisting. So angio was repeated, and since the leaks were persisting, the second treatment, that is 20% from the baseline, around 60 to 70% of the threshold power, there is a resolution of fluid. You can see that the fluid under the fovea has also disappeared. So this subthreshold TTT with this 50% nearly the threshold test burn, we showed the efficacy in that publication on OSLI. So this is quite safe and effective. Compared to the previous studies which were done in the previous decade, we used a much lower power setting and got around 80% visual improvement in these chronic cases. And this is the unpublished now under peer review, low fluence PDT versus the subthreshold technique that we are talking about. So we have a similar group of around 2-year-old CSR on a mean duration, 2 years of CSR, chronic and severe cases, and luckily these two groups have almost baseline OCT features which is same, fibrin, cystoid, degeneration, all in between the two groups. You have the baseline FFA features for these patients also more or less similar, diffuse epitheliopathy or subfovealing blood, whatever be the thing. So the visual outcome was similar between low fluence PDT and the subthreshold TTT, and it was significant in both the groups, whereas even the macular resolution also around 80% and 77% between low fluence PDT and this technique that which is cost effective, around $50 for the treatment. And only thing is, it took around 2 months on a mean for this TTT patient to resolve, where PDT took only 1 month for it to resolve. And number of treatment sittings also slightly more in the TTT arm. So we found almost similar results, and in our context, we feel that PDT is an excellent modality for chronic CSR, but the cost burden to the patient is important in treatment decision in our scenario. Subthreshold TTT is as effective a treatment option requiring marginally higher treatment settings. So that's about subfoveal treatment. Currently, the other indications are mainly the tumors. You have a circumscribed choroidal hemangioma, vasoproliferative tumors of the retina, retinal capillary angioma, choroidal melanoma for the sandwich technique that we follow for thick tumors now in combination with brachy, and small selected retinoblastoma. These are the things which we currently use, mostly the LIO TTT, not the slit lamp attachment. Currently we are using for all these indications. I will be showing the patients post-treatment with the vasoproliferative tumors, angioma, choroidal hemangioma. So, and the other extrafoveal indication would be IPCV and CNVM, which is extrafoveal. For example, when you have an extrafoveal IPCV and you have a large PED, in those situations, rather than a focal laser to a large PED, this would be TTT with or without anti-VEGF in combination would be a good idea. Even peripheral PCVs like this, where you have a subretinal heme and your ICG shows peripheral PCVs, even we have done TTT combined with or without anti-VEGF in such situations. In choroidal melanoma, as you have, the thick tumors, sometimes plaque radiotherapy or brachytherapy combined with TTT in more than 10 millimeter thickness tumors results in better resolution of the in the tumor. And TTT for flat tumors, there is still controversy because of the recurrence and insufficient local tumor control. Even other vascular tumors like circumscribed choroidal hemangioma, the first line would be a PDT. Still, if it is unaffordable, or even for extrafoveal circumscribed choroidal hemangioma, threshold TTT would be a treatment option. Or when you have tumors like this, peripheral vasoproliferative tumors of the retina. In this patient, this was unique because it was in combination with a Goldman-Favre syndrome. This is already a published case actually. So like this, when you do a LIO TTT, beautifully it resolves in these tumors, vascular tumors. And in summary, I would like to say, Chronic CSAR is a best indication, graded subthreshold TTT from lower to higher power, if at all required, around 50%, and it is cost effective, especially in Indian scenario. Vascular tumors, TTT is effective, especially in retinal angiomas and vasoproliferative. Standalone treatment modality, and in melanoma and retinoblastoma tumors, selective tumor types, and as adjuvant treatment, it still has its role. Extrafoveal CNVM and PCV, it is effective modality with or without anti-VEGF injections. Thank you.